Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast Podcast. My name is Terry Fletcher, and we appreciate all our listeners. Thank you for continuing to listen to us for the last year and a half now, and we're very excited to be here. Over 32,000 listeners, so we are very, very happy with the progress and just everything we're doing to hopefully bring you the best information in healthcare. So one thing that I like to do, just kind of a background on me, is when I'm looking for topics, not only do I get your feedback, but I also like to look at a lot of my business journals. I read different medical journals that come in, trade journals, different coding alerts that come in. I'm actually a editorial advisory board member for different, like the coding alert from the Coding Institute for Cardiology, the one for practice management alert, just some different things. And I just like to kind of get a prompt maybe or an idea for some things that are out there. And I started thinking lately when I've been reading some of these things that it's not always what you know, but sometimes it's what you don't know that can hurt you. And the reason I say this is I've been reading some articles on things that concern me in the healthcare field and that can kind of come back to bite you if you're not mindful of some things that are happening within your practices that maybe you don't know about, that you need to be really heads up about. So let's kind of talk about that today. But first, the Codecast Podcast is brought to you by MVMT Watches, mvmtwatches.com, an affiliate of Movado Watch Company. Also, Simple Health Radio, discussing topics related to your health and well-being, simplehealthradio.com. Okay, so what I want to talk about when I mean, what you don't know can hurt you is one of the articles that I was reading recently in the Practice Management Alert by the Coding Institute, and it was titled, Be Careful When Choosing Diagnoses for Discharges. And so the reason this is talking about what you're choosing is because a patient entering the hospital with one condition might not have the same diagnosis for the entire hospital stay. So one thing that you have to keep in mind is medical practices need to have ICD-10 coding smarts so they can be ready when a patient's diagnosis changes during that facility visit. So billing your physician's hospital services with an inaccurate or out-of-date diagnosis could not only lead to lost revenue, but suspect charges because everyone in the practice, has to know when things change. And you also have to make sure that the physician, if they're narrowing down the patient's problem, they may be admitted for chest pain and the physician may be ruling out myocardial infarction and decide the problem is actually, for example, gastrointestinal in nature. So they may think that they have epigastric pain instead. The patient may develop other problems. Maybe they're going to be admitted for dehydration problems, but they start having chest pain. Or there could be some complications, and this can lead to the original complaint to worsen significantly. So you can't wait for the hospital to send you medical records and hope that it's in a timely fashion. That rarely happens. You could be waiting up to 6 weeks after the patient gets out of the hospital for any records from the hospital. So it's really up to you as a coder, as a billing professional, and as a physician to let the payer know and make sure it's in the medical record when the patient's diagnosis has changed, and to ensure that you have access to your physician's documentation via the electronic health record. Make sure that you have a lookup station or something where you can look at these notes based on the services. And you should also be educating your physician and let them know that just because the patient has been admitted with one diagnosis doesn't mean that should be the diagnosis you're going to use for every visit, that they need to make sure they're also looking at the diagnosis on the electronic health record or whatever charting tool that they're using, because maybe they're addressing different conditions at each encounter. So they need to distinguish admitting from treating diagnosis. So if your physician doesn't admit the patient to the hospital, then chances are the diagnosis that he or she treats won't be the admitting diagnosis anyway. So for example, your physician performed gallbladder surgery on a patient 2 months ago. Your physician wouldn't know the patient was admitted for pneumonia unless the admitting physician called the surgeon in to check on the surgery. So your physician would bill under the postoperative gallbladder diagnosis, not the pneumonia. But if you're not billing with the most up-to-date diagnosis, you may not be able to justify a higher level of service. The patient may have been admitted with a simple problem that developed into complications. Maybe a subsequent visit could have been more complex. And so the decision-making has to be justified. But you won't be able to justify a higher level of code unless you know all of the diagnoses and you're checking to make sure that you have them all. And again, we call this best practices. It means that you're doing your best to make sure that you're giving the most accurate information you can when you're submitting information to a payer, because it's always going to be under scrutiny. Your best bet is to stay in close touch with the physician during the patient's hospital stay. And I'm talking to the medical professionals here who are coding and billing, and make sure your entire coding team has access to all the patient's records, not just the admitting or discharge notes. This way you can read all of the charts to ensure that you're assigning the right diagnosis codes every time. And with I-10, now that it's such a collaborative effort and it's something that you have to really look at, this is where you as a coding and billing professional can show your expertise, can show how you have your physicians back when it comes to compliance, and that the diagnoses, not only that they're looking at and addressing, but also the hospital stay is included on your billing form if it needs to be, if it has any factor for medical decision making for your physician. So that's basically, you think that it's only what you're doing, but try not to have tunnel vision. You know, what you don't know could possibly hurt you. Which leads me to another article I was reading recently, and this was in the Journal of HEMA, and it was from last year. And there was a study done with regard to electronic health record medication lists and just how incomplete they can be. And as I'm reading this, I was actually just so surprised at just how this hasn't been a news story. I mean, it's always, a headache and people look at it. But politically, I see them complaining more about what coverages aren't out there and, how this population isn't getting this health care. But when you look at this research on the medication lists and how incomplete they are, and how the interactions aren't being accounted for or accountable by the physicians, this is a problem. So what happened, and this was a study, is it basically said more than half the people whose blood was tested were found to have concentrations of prescription and or over-the-counter medications that were not listed in their electronic health record medication list. And this is a recent study through AHIMA. And it was published in the Journal of American Medical Association back in November 2018. It said investigators developed a blood test that could identify 263 medications, both over-the-counter and prescription drugs. Then they collected samples from a total of 1,346 patients at 3 different medical centers, okay? And they discovered that 78 to 100% of medications were detected as prescribed in the EHR medication list. Okay, that's a good thing. But according to the study, in addition, medications not included in the EHR medication lists were also detected and were more frequently associated with alerts for potential adverse drug reactions. The anxiety medication, diazepam, and opiates were among the most common medications that were detected, despite lack of evidence for an associated prescription. So investigators also concluded this is because they have a high tendency for abuse, which is true. Medications targeting cardiac conditions were also commonly detected without prescriptions being noted in the patient's chart. That's scary to me. Most of you know that, my number one specialty is cardiology, and then I have 8 other specialties that I deal with. And so when I read something like that, it definitely makes the hair on the back of my neck stand up going, okay, so I'm going to expand some of my audits clinically to look at that, not just documentation-wise, but then look at, okay, where are some of these things that maybe could be missed, because what you don't know can hurt you. And this goes back to what I was talking about last week. So for those of you that, were confused or still confused over what the E&M 2019 guidelines are and what you have to document, we talked about not having to repeat information within the medical record that the ancillary staff, so your medical assistants, your RNs, your LPNs, your LVNs, your lower level clinicians, are inputting into the system. But that doesn't mean you don't have to ask questions, that you don't have to expand on that statement of chief complaint or that statement of HPI, history of present illness. And, more important, when we're talking about medications, a disproportionate number of potentially interacting medications were noted among patients without evidence of a prescription in this study, suggesting that healthcare professionals may be prescribing and making clinical care decisions with incomplete information. And so I'm a little concerned when I see Medicare saying, well, let's make documentation easier without understanding or recognizing that we have a problem with incomplete information, with, basically no checks and balances. So a patient's taking this medication, but nobody told them they're taking this medication. And let's face it, when we're doing a history of present illness or we're doing a medicine reconciliation or a check, we're only as good as what the patient tells us and what they give us. Is anybody actually looking at their prescription history? Did anybody pull scripts? Because patients forget. They bring in all their bottles and they forget, oh, wow, yeah, I'm still taking that one way back in my medicine cabinet that's expired, but I know it's there. Or I don't really want my doctor to know about this one, but that can, also counteract between the medications or the physician's decision to prescribe a medication currently. So when we talk about this from a best practices standpoint, we want to make sure that these things that are hidden, these things that could be a problem, are things that we are trying to avoid, that we're bringing them to the forefront, that we are making sure that patients understand that it's not just what we know, but it's what we don't know. And it's their responsibility to give us as much information as we can so that you can make informed decisions. And so what you don't know can hurt you. And then I want to get to my coding question. So when we talk about coding here, a lot of patients, and this is kind of a coding billing question, so shout out to my billers that are listening in today. We often get, and here's one that came in, Terry, we often get patients who call the practice with questions regarding their explanation of benefits, so EOBs. One complaint is that the EOB looks like a bill. What would be the best practice for dealing with these calls? Okay, so this is one of my Idaho clients. So explaining explanation of benefits to patients who are confused, it can be a challenge for all medical practices. Patients don't always understand what you're trying to explain to them. So first, I would let them know that this is not a bill. So an EOB is not a bill, but it's a preamble to a bill. So this is informing you basically a confirmation of what was submitted by your physician. And this is what we're looking at or what your payer is looking at to pay out or to deny or not to pay out. And there's also a website called healthinsurance.about.com. It's a great website. And it just gives some explanation in lay terms to patients and how to read their explanation of benefits and any questions they may have on, how to make sure that their coverages are getting their insurance claims paid. But it says an EOB is a form that payers send patients after they reimburse for medical service. And so you should get an EOB if your private health insurance, a health plan from your employer or Medicare. Okay. And basically if you've had medical services. And then this healthinsurance.about.com goes on to say the EOB will reveal one of two outcomes for the patient. The EOB could reveal that the payer covered 100% of the patient's services. And we talk about allowed services. It's rarely what was billed. And the patient doesn't owe the payer any money if it says payment by patient or if it says patient responsibility. Talk to the patient and ask him or her if the EOB indicates that the patient owes money. And it'll say again, patient responsibility. If the patient doesn't have an outstanding balance, give him a brief explanation of the EOB, again, explanation of benefits, and tell him to hold on to it for his records and let him know he can contact the practice with any more questions, or he can contact his payer. Sometimes we like to direct them back to the payer. They are the subscriber and they're going to have to learn how to do it. Number two is the EOB might also reveal that the payer did not cover 100% of the patient's services. And so there could be several reasons why the insurer might not cover any or all of the service. And it could be constraints of the health plan, could be deductibles, network versus out-of-network providers. But when the patient calls with questions about an EOB that contains an outstanding balance, you really need to send them to somebody in your office that is the medical insurance billing specialist, if your practice employs one. So you are the professionals that can help explain that EOB to the patient. And they can also help with who to contact from the payer should there be any follow-up questions or anything like that. But try to have a staffer dedicated to this area of coding and billing so that your patients aren't talking about somebody at the front desk that says, don't worry about it, or talking to a physician in the room saying, oh, I'll talk to my staff, and what the patient heard is, you don't have to pay that. And they basically hear what they want to hear. So you want to have somebody that really understands how insurance works. And hopefully your office or practice is broken down into payer specialists. So I want to know who does Medicare, who handles Blue Cross Blue Shield patients, who handles the, different private or commercial plans, who does Medicaid. And those people should be those professionals. And I'm going to call all of you professionals. That's what you are. You should be an expert in that field. You should be catching up and, informing yourself on some of the information for that payer, always checking their websites. What's new? Payers now only have to post things publicly on their website. They don't have to tell you. So even if you're a provider, as long as they've informed, and it's such a loose rule, and they've put it on their website somewhere, they don't have to actually send you a specific letter. It's a courtesy if they do. But think about it. If you continue to have a day where you're checking different websites, let's say you're the billing professional for Blue Cross Blue Shield. And in some states, okay, I'm in California. So if you're in California, for example, you would bill the California Blue Cross Blue Shield. But what if a patient has Texas Blue Cross? You still bill California and then they reroute it. The only exception is Michigan. But let's say that you're in Texas. Well, if you're in Texas, no. In Texas, their state says you bill it to whatever the plan says. So you need to know what your state says and then what the plan says. And also understand that, let's say you have two patients in your practice, parallel insurance. So one has, and I'll just pick on Blue since I'm there. One has Blue Cross of this company and one has Blue Cross of this company, and it's the same Blue Cross. But one is I don't want to say, let's say a median level executive, and the other one is a higher management executive. Sometimes, even though they have the same insurance, they'll have different benefits based on their package and based on their position in their company. You need to know that information. And so I see that sometimes missed. But try to be the expert in what you're doing. It doesn't matter what your job is, whether you're certified or not, coder, biller, billing professional, LVN, LPN, nurse practitioner, even physician. When it comes to the financial health of your practice, and this is actually my motto, it's basically, we are dealing with the business of medicine. And you have to be smart about it. You have to make sure you know the things that can hurt you and the things that may not be, in your face right out there, and you have to find those out. You need to make sure that patients are well informed about what can be paid, what isn't paid, what their policies are. And patients, they're there just because they're sick. So they're trying to figure out, okay, who can help me? So even though it can be frustrating sometimes, don't take it out on the patient. Be that proactive person that can find this information for them, because let's face it, we're dealing with patient satisfaction surveys. And actually, I'm going to talk about that in one of my next podcasts, and just dealing with, again, best practices. And I like to focus on that. We're in 2019. We need to make sure we're at the top of our game. We're getting the patients that we want. We're getting the payers to continue to contract with us. And so this is just letting us and kind of giving you some information on how to be that best practice, and making sure that not only clinically that you have the best physicians there and the best clinicians, nurse practitioners, PAs, mid-levels, everybody back office, but also you have the best business of medicine financial practice than anyone else. And that's what I'm here for, to make sure that you've taken your business of medicine to the next level. So that's what, I really wanted to focus on today. What you don't know can hurt you, and be heads up and proactive about a lot of this information. So I wanted to thank our partner, Dasassin Music, rapper, writer, music producer, collaborator. Check out his latest album, MMIL, at dasassinmusic.com, DASASIN music.com, iTunes, Spotify, Tidal, and all streaming and download platforms, dasassinmusic.com. So my little personal tidbit for the week, I've been doing some decorating, really wanted to change my mindset a little bit for 2019. So I brought in some artwork into my office. I'm actually looking right now at a really nice sepia black framed big giant sailboat on the ocean. I've got a huge giant clock in my office that also has a black rich frame. I really like giant clocks. I like them to almost take up the whole wall. That's kind of a weird thing for me. Too much fixer-upper watching, apparently. Also in my home, I changed out a couch and a coffee table and new rugs and carpets. If you just feel like you need a change, it doesn't mean that you need to check out of life, completely. Maybe just, put up a picture or put up a new piece of artwork or get a new rug or, get new bedding, get something that just makes you feel like you've made a change and something you can look at, something you can touch, something tangible. And hopefully that'll just give you a little bit of perspective to continue in that process. I'm going to continue to make some upgrades in my office and at home, and hopefully you'll do that as well. Even something as little as change out the toothbrushes in the house, put in a couple of new towels in the bathroom and actually see if anybody notices. That'll be the fun part. So everyone, go out and make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.